We are going to discuss about cardiomyopathy. So we have restrictive cardiomyopathy and hypertrophic cardiomyopathy. In that, what do you mean by cardiomyopathy, guys? Cardiomyopathy means enlargement of the heart. Okay, heart means here left ventricular mass will be seen. Ventricular wall ventricular wall thickness will be reduced or it will be normal. So what will happen, why this is occurring means due to the mutations in the genes, like we have beta myosin chain, and we have mutations to myosin C chain and troponin proteins. Yes, no, we have actin myosin complex will have. So normally what will happen, this myosin head will go and attach to the active sites of the actin, and the contraction begins. And when this molecule of calcium gets attached to the troponin C protein, then the T and I, which is a troponin inhibitor, will get removed from this active binding site, and the active sites will get exposed. Then this myosin head will go unbind and the contraction begins, right? This is normal mechanism. And we have beta myosin chain which gets attached to the actin and this contraction. So against these proteins are getting altered, right, due to some mutation. So this is genetic, right, autosomal dominant pattern. So males also get affected. If it is X-linked, most commonly males only will get affected. If it is autosomal dominant, then females can also get affected, right? Am I correct? X-linked means in males only one X chromosome is there, so males can get easily affected, right? So you are saying ventricular mass, left ventricular hypertrophy, sometimes there may be right ventricular hypertrophy. Then what will happen to valves? So mitral valves and tricuspid valve incompetence also may be there. They may also get dilated, right? So we'll have so this muscle, cardiac muscle, we know it is like involuntary muscle, but it is striated muscle, right? It contains both skeletal and as well as smooth muscle features, right? We know that. And we have a muscle contains of muscle fibers, and intern muscle fiber intern consists of the myofibrils. So here there will be myofibril loss, and interstitial fibrosis will be there. So and if there is any myocarditis also, then it leads to cardiomyopathy, right? So and if there is any fibrillary loss and there is fibrosis going on, it means our immune system is active. So there will be T cells aggregation there, right? T cell infiltration will be there. So as we already discussed, it is genetic problem, autosomal dominant problem. So we already discussed myocytic proteins will get affected. So some X-linked inherited skeletal muscle dystrophies will also be seen, will also leads to cardiomyopathy. Those are Becker's and Duchenne muscular dystrophy, DMDs, right? So late autoimmune reaction will occur due to myocarditis. Okay, what are the clinical features? So when do you suspect this patient has hypertrophic obstructive cardiomyopathy means? So normally these patients will be asymptomatic. They will come for other problems, like they will come for arrhythmias, or they means due to the tachycardia, means palpitations, tachycardia, breathlessness. With these symptoms the patient will be coming. Okay, sometimes syncopal attacks. Then during investigating investigations you will do obvious X-ray, right, CXR. So in CXR you will find some thickening in the left ventricle. So then you will suspect this is cardiomyopathy case, right? So up to then you won't get that suspicion in these patients until unless they come with some other problems, other cardiac problems. So and will have so dyspnea, angina, and syncope. So sometimes sudden death will occur if it goes unnoticed. And we know ASD means angina, syncope, and dyspnea. This is a classic triad we will see in aortic stenosis. But here there is angina and breathlessness and syncope on effort. Here all are on efforts. Angina on effort, and syncope on effort, and this will be on effort. So you said beta myosin heavy chain will be involved. So if beta myosin heavy chain gets involved, then there will be, it is associated with the marked ventricular hypertrophy. If I told three mutations, right? One is beta myosin and another one is troponin. If it is troponin, there will be exercise induced hypotension will be there to the patient. Okay, and sudden death is also chances are more. If it is myosin binding a protein C, means they will present with hypertension and arrhythmias. Okay, I written here these three: beta myosin, troponin, and myosin binding proteins. Okay, that's all. And so how will you manage, and what on inspection, what you will see, on palpation what you will see, there is hypertrophy, and so that in apical impulse it will be double impulse will be seen. Okay, due to this ventricular mass and all, so you will feel a double impulse apical beat, and you will feel the palpitations with your tip of the forefinger on when you localize this apex beat. And then we'll have in HOCM we'll have a jerky pulse. Okay, jerky pulse will be seen. And what murmur you will suspect means mid systolic murmur at the base, and pan systolic murmur will be seen at the apex. Mid systolic at the base and pan systolic will be at the apex, right? So what are the risk factors for sudden death? So it will be it may be excess induced hypotension. You know, APJ Abdul Kalam also, while teaching in an institute, he suddenly collapsed. It may be due to HOCM. We can't say, some cardiac pathology is there. So it may be due to this HOCM. Okay, non-sustained ventricular tachycardia, and increase in the left ventricular wall thickness, exercise induced hypotension may be there, recurrent syncopes. These are the signs, risk factors for sudden death in the hypertrophic obstructive cardiomyopathy. So what will you do? What investigations do you want to have in this patient? And here in this patient there will be deep T wave inversions will be seen in the ECG, and these findings will be as similar to those of the aortic stenosis. Okay, aortic stenosis. And investigations will be ECG and cardiac MRI. Management will be, you have to transplant the heart, because it will be if once irreversible changes develop in the muscle, then cardiac transplantation is the only option. Then what drugs can drugs prevent this means, you can give beta blockers to prevent the sudden death in case of the hypertrophic obstructive cardiomyopathy. And AC inhibitors are like cardioprotective AC inhibitors, ARBs you can use. And okay, then if there is any then that's it, guys. Okay, and sometimes you will see like this interventricular septal hypertrophy, generalized hypertrophy may also be seen. Okay, beta blockers, AC inhibitors, and ARBs. Okay, sometimes septal hypertrophy, it may lead to severe obstruction. Mitral regurgitation may also occur, and sometimes anterior mitral valve leaflet may get dislodged. Okay, it may lead to like it may leads to this also. Okay, okay, that's it, guys, today. I hope this video is helpful. HOCM in many ICUs, this is commonly placed, means on that diagnostic sheet, it is like that this patient has HOCM, like that is there. So next time, means on next video we will discuss atrial septal defect, because recently we saw a patient with the characteristic murmur, which is a systolic murmur, which is heard in pulmonary which is placed in the second intercostal left side. So and it is heard almost, it is radiating from that pulmonary area to tricuspid, and every area like mitral area, every area is involved. So on every area we heard a murmur. It is very interesting case, guys. And she has a JVP elevation is there with normal AC Y without any descents. And it's nice case, guys. So next time means in next my video we'll discuss this atrial septal defect. Okay, so the only congenital heart disease which progress to adult stage is atrial septal defect, definitely. And so we'll classify the heart diseases into cyanotic, acyanotic. We'll discuss ASD in detail, and in more we'll do cardiology, and probably I will learn and I will tell ECGs also. Probably I have some confusion in ECG. And in that patient we saw, in atrial septal defect patient, we saw that a characteristic RSR pattern, and some P pulmonale also it is visible. That ECG also I will place in that. I have that ECG photo. So for this now class, HOCM I taught due to, just summarize, it is autosomal dominant due to mutations in the beta myosin and troponin and myosin C. And we have if it is myosin C, the patient will come late like hypertension and arrhythmias. If it is troponin, the patient experience exercise induced hypertension. And if it is what is that beta myosin, then the patient will come with marked ventricular hypertrophy. And signs also will saw, and ECG pattern will be similar to aortic stenosis. And we saw double apical impulse, and except what is the difference between aortic stenosis and this means we'll have jerky arterial pulse here. And it will be remaining asymptomatic. The patient lately comes. Sometimes there may be mitral regurgitation associated with due to the anterior mitral leaflet motion, and means movement of it. And systolic murmur, mid systolic at the base, and mid systolic murmur at the base, and pan systolic at the apex murmurs. And HOCM will be diagnosed when the patient will come from other signs. And investigations we had already saw, like CXR, cardiac MRI, and treatment, beta blockers, AC inhibitors, ARBs. Definitive treatment, and which should be permanent is cardiac transplantation in these patients. Okay, this all we saw about HOCM. Okay, I'll definitely do cardiology. Daily I'll take half an hour and spend for cardiology. Okay, so many days after I'm taking class, I hope this class is somewhat useful to you. Thank you, guys. Thank you.